Hi, my name is Alyssa Deiters, and I will be presenting results from complex abdominal reconstruction at a non-academic institution can favorably compare to major academic centers. I have nothing to disclose. There's a large movement to centralize complex procedures. Multiple studies have shown that high volume centers outperform lower volume centers with certain procedures. There's very differing terminology in the literature. High volume is pretty obscure. There's not a designated number for hernia repairs to make it a high volume center or high volume surgeon. Complexity is ambiguous. Some papers try to define criteria to make it a complex hernia, such as size and location, contamination, history and risk factors, and clinical scenario, but there's no standardized scoring system. And are good outcomes due to individual surgeon volume and experience, or does being at an academic center make the difference? More complex cases tend to get referred to high volume centers, which are typically these academic centers. So they get the higher volume, the complexity, and financial benefit from being deemed a high volume center. Establishing these successful tertiary hernia referral centers or high volume centers requires certain elements, such as participation from the institution, experts, interdisciplinary collaboration, and ongoing evaluation of outcomes. Success is marked by case volume and referrals, but mostly evidenced by improved outcomes. So if you build a tertiary high volume center, the referrals will come, but should they? Do we necessarily need these centers to have good outcomes? And does every patient needing a complex hernia need to be referred to these centers? So our question was, does our non-academic center achieve comparable results regarding abdominal wall reconstruction as a major academic center? These are our study goals. We're reviewing our practice patterns and outcomes and comparing our outcomes with major academic centers. Our center has a 150-bed hospital with 5 ORs. There's the same teams and first assist for each case. There's no trainees. It's basically 2 surgeons that do 50 to 60 cases a year. They participate in AHSQC. These are pictures of some of their complex hernias. Study design was using the AHSQC database from 2016 to 2019. Academic centers were the high volume centers versus our center, which is non-academic. Complexity was described by component release or myofascial release. And then we compared the data points. So we had 180 patients at our community hospital. The demographics were very similar between our hospital and the major academic centers. Operative times were significantly less at our community hospital. There was more planned concomitant procedures at academic centers, but our center had significantly lower length of stay than academic centers. Overall complications were lower at a community hospital, our hospital, but major complications such as cardiac arrest and mortality were statistically higher. Readmission rate was nearly twice as frequent in our hospital than at the academic centers. So comparing our non-academic community hospital to major academic high volume centers, we actually saw a decreased length of stay. This mostly, we could contribute it to hospital-wide efforts at private hospitals to get patients discharged for improved metrics as one of the factors, but does this lead or contribute to the high readmission rate? Are people going home just too quickly, or is there that we don't have enough staff and resources to provide the adequate follow-up and quality care after surgery. Another factor is that there's no in-house staff for our facility. So in the evening, if someone comes in, they're mostly just admitted and then seen in the morning. There's no in-house residents or mid-levels. The lower operating times could be contributed to having no trainees and the same efficient team for every case. The higher mortality, our center versus academic centers, we don't really have a collaborative group of specialists who have the same buy-in on these, big complex hernias. And we do need better coordinated care for preoperative evaluation. Overall, the surgical outcomes appear comparable, but the lack of dedicated staff for data entry and monitoring and follow-up could definitely be improved, and that may play into the postoperative readmissions and other outcomes that are different between our center and an academic center. We need administrative hospital buy-in to have the same goals and help provide resources needed for this postoperative follow-up and care. So who should be referred to these high-volume centers? Multiple studies have shown a strong association between individual surgeon volume and results. Clearly, well-trained surgeons do possess the skill set to perform these complex repairs, but what happens after the surgery drastically affects patient outcomes. Overall, non-academic centers can provide comparable care and expertise, just like major academic centers, but it may, depend on individual surgeon volume at these non-academic facilities. But we really do need dedicated care coordination and a continuous review of supporting staff and outcomes to assure quality care. Us as a facility need to further investigate our readmission and mortality rates, but ultimately, further research should be done to determine factors that would identify which patients need to be sent to these specialty centers. Not every patient with a complex hernia might need to be sent there, but certainly some do for the follow-up and the resources that are provided at these large volume centers. Thank you for listening to my presentation. I look forward to any questions you might have.